infected pocket of combined, well-controlled abscesses inside the pleural cavity. Right? So, 60% of the time, they have some sort of underlying pathology in the lung. Okay? We call those parapneumonic empyemas. Okay? But they can just be from pneumonia that ends up being an empyema. Okay? Staph is the most common cause, or most common bug. It can be polymicrobial. Okay? Depends on what other pathology is happening in the lungs. Say they were a chest pneumothorax, that they got a chest tube, it was a dirty chest tube, right? The first one was a dirty one for whatever reason. And now they have just an overgrowth of other bugs in their chest. We can see a lot of things. Rarely are these due to like a fungus or a parasite, but it can happen. Okay, especially in certain regions of the U.S. and of the world. More so gonna be a critically ill patient, could be very uncontrolled diabetic, that kind of thing, right? You're not gonna see a fungal empyema very often, but they can happen. Okay. All right, so the clinical course of it's building into what is an empyema, okay? So the first phase is you have an acute exudative formation. It's a pleural effusion, okay? It's just fluid, it's exudative, more so it's starting to become infected, okay? You're gonna have low viscosity, you're gonna have a white count. Within that tissue, you're gonna have an LDH, okay? But normal glucose, normal pH. Pleural remains mobile, okay? That fluid remains mobile, so if you put them on their side, it changes with gravity, okay? And when I say pH and glucose, that's of the fluid, not of the body, but of the actual the fluid that we took off from the thoracentesis, okay? Then after a couple days, the fluid inside starts to become more turbid, starts to become thicker. You have higher white cell count, higher LDH levels, higher, or the glucose and the pH go down though. Why do you think that is? Bacteria like eating glucose, okay? So you're feeding the bacteria. Okay. And then you get the start of the rind. It's this fibrous material, fibrin that deposits on the outside of this, and then within a week, you really get a thickened rind. The pleural glucose is less than 70, okay? The pH is less than 7. It's a well-controlled now empyema, okay? It's an abscess within the cavity. It won't depend on gravity. Now the fluid within that abscess might still depend on gravity, but it has now made its nice little cocoon of gross fibrin, okay? So the abscess itself is kind of stuck to the parietal pleura. The fluid inside may still be a little bit mobile, but the fluid collection itself is kind of just stuck to wherever it's kind of organized at, okay? All right, so they're gonna have fevers, they're gonna have pleuritic chest pain, they're gonna have dyspnea, hemoptysis, productive cough. Okay. Kind of just sounds like pneumonia. But they are also going to be anemic. They're also going to be tachycardic, tachypneic, and have decreased breath sounds with dullness in that region. The biggest thing now is that now we're starting to see clubbing of their fingertips, and we might have occasional pulmonary osteoarthropathy, which is one of those things that you don't see very often. So it's one of those, like if you see a pneumonia, but then you start seeing clubbing of their fingers when they didn't have clubbing of their fingers before, you should start thinking of, instead of like CHF type picture, this is more acute, think more empyema or some sort of infectious process happening in the chest. So chest x-ray is the most important non-invasive diagnostic test. Okay. But we still might need to do bronchoscopy. especially if we need to rule out obstruction, right? They're having a really bad VQ mismatch, they're just not ventilating correctly, maybe this empyema is, compressing on the actual lung itself, and it's just you need to potentially open up that airway, put a stent in, or just figure out what that obstruction is. Sometimes we can't do anything about it from the inside of the lung, we have to treat it from the outside. And then the chest CT with IV contrast, every patient with suspicions of an empyema must get one, okay? We need to know what stage it's in, and we can only really do that by CT with IV contrast. We can obviously know if we are doing a invasive surgery, we can see by then, but we really want to know what it looks like before, this is for surgical planning, right? We're trying to decide, can we just treat this with a chest tube, or do we truly need to go in because this is a very septated, it's got a huge rind that a chest tube is just not going to fix. We really have to go in and scrape all of this gross infectious material out of the lung, or out of the pleural cavity, okay? So we get that chest CT to really see what this empyema looks like on the inside. Okay. All right, now, again, we need to still do a thoracentesis to figure out what type of fluid is in that abscess. Okay? Most of the time it is still infectious and it's still a exudative process, but there are still some cancers, some malignancies that can mimic these. Okay? So even though we want to do the CT, that's more so for surgical planning, looking at what it looks like from the inside, but we still have to test that fluid to figure out what type of fluid it is. Okay? We can also take that fluid and get cultures from it so that now we have specific antibiotic coverage. Okay? So we still have to take the fluid, still have to do a thoracentesis. Like I said before, the protein count is going to be above 3 if it's exudative. Okay, if it's a true empyema, an infectious empyema, okay, protein's going to be high. Your pH is going to be low, glucose low, and your LDH is going to be high. Okay. Goals for treatment: we really need to control the infection. These guys are going to be on IV antibiotics probably for a while. Okay. They could be 4 to 6 weeks potentially. So we may need to put a PICC line in so that they don't have to stay in the hospital to get IV antibiotics for 4 to 6 weeks. We need to somehow remove that material, that infected material, to try to re-expand the lung. There's many ways we can do that. The first way is doing a CT, chest tube, not a CT, chest tube, okay? That way we might even have to do 2, right? One is gonna instill some just normal saline or sterile water, something that's sterile so that we can actually irrigate that abscess, and another one to then drain it. Okay. You can still do it with one chest tube. Okay, we put some irrigation within the chest tube. We clamp off the chest tube, let it sit for a minute, and then we reopen it and then let that whatever we put in there to irrigate to drain out. Okay, that's first line treatment. After about 3 days, we might have to do another chest CT to see if we're making any headway, if this is the way we did it. If this is the way we treated it with a chest tube and irrigation. Most of the time we try to do a CT after 72 hours. We may have to do it sooner if the patient starts to deteriorate. Okay? But most of the time we wait about 3 days, let our treatment and the IV antibiotics work, and then if the CT doesn't look any different or worse, they're most likely in line to get a VATS then. Okay? And with VATS, we already talked about doing it with the camera, okay, the little ports. Sometimes, depending on where that abscess is, the VATS isn't necessarily the first line in terms of surgery, right? If it's right next to the wall and it's smaller, development of that rind, we might be able to take care of it with the VATS. Otherwise, we're gonna have to open them up and actually scrape out, like say it's been a couple weeks and it's just not really can't get enough out. Okay, we can't get that source control. At that point, we're gonna do a thoracotomy and actually scrape and get all of that purulent material out and leave chest tubes behind so that we can watch and create additional drainage and re-expand that lung. All right, this is an FYI, okay? I love algorithms like this. So if you have, I'm not necessarily going to test directly from this, but if you're an algorithm person, this is a good way, a good pathway of like, if you have this, then you're gonna do that, or if it is this, you're gonna do that, okay? So again, I'm not gonna test directly from this, but if you're an algorithm type person like I am, I do supply these so that you have a little idea of different pathways we can take. All right, cavitations. So these are within the lung parenchyma. Okay, these are abscesses within the lung or fungal balls within the lung. Just depends on what type of bacteria or fungal bug is in there. Okay, can be confused with blebs. Blebs are an outpouching or an expansion of those alveoli that look like weirdness, like that's a CT of a bleb, okay? Sometimes you might confuse that with a cavitation, but normally blebs and boli will not have any fluid within them. They're very thin-walled, versus when you look at this, you know, nice circular abscess or cavitation in the chest, that's pretty, that wall is thick, okay? Just like if you had a abscess in your chest or in your belly, right? You're having that fibrous material make that that collection around it. Same thing with an abscess inside the parenchyma. Okay, it's going to have that nice rind on it. Okay, so normally these people are pretty healthy beforehand. Okay, when it's a primary. How we treat primaries when they're healthy, they don't have any underlying issues, we just do an aspiration. If it's a secondary, so they have an underlying cause, they have a coccidioidomycosis or some other weird systemic thing, okay? They have some sort of, like the slide says, necrotizing pneumonia, that kind of thing. Might change, we can't necessarily just do aspiration. Okay, at that point, we might have to go in either with a VATS or a open thoracotomy to try to most likely wedge that part of the lung out. Okay, we're not just going to remove just the abscess. We're going to remove that entire part of that lung to contain it. But you have to fix the offending cause, right? If we just do a lung wedge resection just to get this abscess out, it's not going to treat them from their underlying condition. Okay, if they have necrotizing pneumonia, if you don't treat that pneumonia, it's just going to come back and worse. Right? We have to treat both things. Okay. Sometimes when we treat the actual offending agent, the abscess then goes away. We don't actually have to then go in and do any surgery. When I say necrotizing pneumonia, I want you to think liquefactive. And necrotizing is like basically necrosis, okay? But instead of it just dying, the lung tissue becomes liquid. It's like a jelly, it's gross, okay? So when you think of like the necrotizing pneumonias, that's when you think, okay, it's that fluid on the inside of that pneumonia is going to turn that tissue into jelly and liquefy it, causing an abscess. And this nice little ball of an abscess. Okay. All right, symptoms. Kind of the same, cough, fevers, putrid sputum. They can have hemoptysis, dyspnea, pleural chest pain, depending on where, if it's on the periphery. Okay, they're gonna have weight loss though. That's a new one. signs of pleural effusions, cachexia, and sometimes it actually makes a fistula from that abscess to the outside of the chest, and now you have a draining wound from that abscess through the chest. Okay, like a pulmonary and cutaneous fistula. Gross. Want to absolutely get a white count and a sputum culture, along with all the other normal bacteria and infectious type things, but the white count and the sputum culture are what you need. Okay. Chest x-ray, CT chest, with IV contrast, you need to differentiate it between an empyema and an abscess, right? So if the abscess is right abutted to the pleura, okay, the parietal pleura, you might not be able to tell on x-ray that it's an abscess versus an empyema. Because remember, empyemas are between the visceral and the parietal pleura. So if the abscess in the lung is right up against that wall, on x-ray it may look like you have an empyema, when really it's inside the lung, not outside the lung. So that's what the CT does, it differentiates them. You can actually see where the lung ends, depending on where the abscess is. Okay? All right. IV antibiotics, 4 to 6 weeks. The most likely leave with a PICC line, just like with empyemas. Okay? If they don't respond to those antibiotics, that's when we go in and do the percutaneous drainage. Normally they go away within, or get treated, resolved within 3 to 5 months. So they may be following up a lot. They should be seeing a pulmonologist with this, okay, to monitor their lung function. They may need to do chest physiotherapy, okay. Trying to keep their other comorbidities optimized, right? If you have a diabetic, keeping them well controlled is going to be key, right? If you have an uncontrolled diabetic, do you think their abscess is going to be healing correctly? Probably not, right? So optimizing all the other health things. So failure, if we do not see any clinical or radiological improvement after 4 to 6 weeks on antibiotics, that's when we go in and do either the VATS or open decortication, depending on where it's at. And again, we might have to do a lobectomy if we need to. All right, this is how they look, potentially, on chest x-rays. Okay, empyemas, walled off. You might see the diaphragm unless it's low and you might not be able to, okay? But it's a contained abscess or fluid collection that's stuck to the wall. If it's pneumonia, it's within the parenchyma, right? It's not a solitary collection. It's just kind of within the tissues. And then abscesses, you'll see those round cavitations. They may have a fluid level within them. Just depends. But that's normally what you'll see on x-ray. Okay. Now, if this one didn't have that fluid level, right? If this one didn't have that fluid level, could you theoretically, and it was just white in the middle because it's been there a minute, do you think you could differentiate from the x-ray between an empyema and an abscess? No. Can you actually tell that this is not the empyema that's not inside the lung from an x-ray? No, you can't, right? It might still be within the lung, so you have to do that CT to see exactly where the lung tissue is. And it has to be with IV contrast to show that rind and show where that rind is. All right, switching now to lung cancers. Most common cancer-related death in the U.S. Tobacco smoking counts for 85% of all lung cancers. This is nothing new, you've all heard this before. Exposure to asbestos, as much as maybe 23% of all lung cancers. So if you have a question that has, and Pants loves to do this, you have a shipyard worker, what do you think? Asbestos, mesothelioma, right? That's the big law thing right now, the big settlement, right? But functionality, there's different types, right? We have squamous cell carcinomas, large cell carcinomas, and adenocarcinomas. Small cell carcinomas account for about 80% of all lung cancers. Okay. When you have small cells, about 15 to 20. And when you have bronchial gland adenomas and carcinoids, including carcinoids, they're pretty low and pretty rare, right in the last 5%. Now, when you look at where you're going to find them, either centrally or peripherally, depends on potentially what type of carcinoma you're looking at. Okay. Squamous cell, a lot of central. Okay, so you're going to have more central issues: bloody sputum, coughing, dyspnea, chest pain. Okay, but when you start looking at large cell, potentially, or adenocarcinomas, they like the periphery. So you're going to have pleuritic chest pain. You might have a little cough, but you're not going to necessarily have that hemoptysis unless it's invading internally towards the bronchus. Okay. So sometimes your presentation of the patient can actually help you differentiate between which one's which. Unless it is a larger stage and it's already invading certain things, then it's harder to tell. Okay, so central tumors, just like I said, cough, hemoptysis, respiratory difficulty, pain, pneumonias, right? It's blocking off, it's putting pressure on your main bronchioles or bronchial tree. So you might have increased sputum that is unable to get up because it's obstructed. Versus peripherally, you're gonna have that chest wall pain, the pleural effusions, maybe having those peripheral pulmonary abscesses. Right? With the peripheral tumors too, especially the ones up here, right, the apex ones, these two syndromes, Horner syndrome and Pankow syndrome, are very, very common. You're actually going to most likely catch a peripheral apex tumor because they're coming in with a picture that looks like Bell's palsy. Okay, and then they have a mass of a lymph node, or potentially their mass, right in their sulcus. Okay, so Horner syndrome, you have ipsilateral, so same side, meiosis, ptosis, and anhidrosis. Okay. When you have Pankow syndrome, some also call this a superior sulcus sign. Okay. You're going to have ipsilateral shoulder pain. You may have ipsilateral arm swelling, okay, because it's putting obstruction on the lymph to be able to bring that lymph tissue back. Okay. You may have that C8 to T1 arm pain, like the nerve distribution burning pain. Okay. It may also include Horner syndrome and the superior sulcus lymph node, that swelling way up here. Okay. Normally though, those are going to be squamous cell. Okay. All right. Symptoms due to effective regional spread. It really just depends on where it spreads to. If it goes in into the neck and you have some hoarseness from the recurrent laryngeal nerve paralysis, if it goes down towards your main bronchus, you may have dyspnea. Okay. It just depends. Metastatic disease, you may have anorexia, weight loss for no known reason. Okay, weakness, malaise. If it has now migrated and has a metastatic, it's then migrated to the liver, right? You're gonna have jaundice, you may have abdominal mass, you may have bone pain if it goes to the bone. You may have pathologic fractures, right? Someone fell, an old person fell, and they shouldn't have broken anything, but now you have a femur fracture or an arm fracture, right? You still have to, like the fall didn't necessarily have enough force to fracture their humerus or their spine, and now all of a sudden, like, they have these pathologic fractures, okay? Or they're just walking, and then all of a sudden it fractures, okay? It just depends on how bad that spread is and how bad it's eaten up that bone, okay? If it has gone to the brain, okay, lung Lung cancers love to metastasize to the brain. So you may have their first symptom being mental status changes, balance issues, neurological deficits that are not otherwise explained. Okay? So given where and what symptoms they have may indicate where that spread has gone to. Okay? We kind of touched on this already. So central being central in the hilum, okay? Peripheral being more on the periphery. Narrowing the bronchus, right? Starts most of the time centrally, can be peripheral if it's bad enough and it's now invaded inward, but periphery likes to invade out. So most of the time, you may just have that chest pain or maybe asymptomatic. Okay. And then the panneoplastic syndromes. So these are the ones that are actually being caused by some hormones or depletion of some hormones. It really just depends on what type of neoplastic, paraneoplastic syndrome it is. So sometimes you might not know unless you actually get a biopsy of that mass and figure out what it is and what it's doing. Okay. So for panneoplastics, these are some of the things. The three highlighted boxes are the ones you're going to most likely see. So carcinoid syndrome, right? You're going to see that with carcinoid small cell. Small cell loves to play around with your ADH, so you may have symptoms that look like inappropriate antidiuretic hormone issues. And then unfortunately all three love to do the hypertrophic pulmonary hyperarthropathy. Okay. Again, that's pretty rare. You really don't, I have never seen that unless, I'm guessing more so like the surgical oncs and the medical oncs will see that more so than me. So I can't really speak to that one because I just don't see it. But all three of those types of cancers can produce that. Okay. So non-small cell loves to screw with your calcium. You will have hypercalcemia. And because of that, it loves to go after your bones. So most likely metastasize to your bones. Okay. Small cell, ADH. Okay, so you may have SAADH leading to low sodium. You may have mucotinic, the pigmentation of your skin. Melanin, sorry, that one. Okay, you might have hyperpigmentation of your skin. If it's ACTH, you may have Cushing type syndrome or just glucose intolerance. So small cell loves your ADH and loves to play with it. Adrenal insufficiencies could be any cancers really that metastasize to your adrenal glands. It could be lung cancer, it could be many other different cancers. So it's just one that if you see adrenal insufficiency and you have fatigue, salt craving, weight loss, electrolyte imbalances, before you just say, yep, it's adrenal insufficiency, just make sure you're not dealing with any other cancers. Okay, which means you might have to take a little biopsy of your adrenals to figure that out. All right, so Pancoast tumors, lung apex. Like I said, it's kind of synonymous with the superior sulcus tumors. Okay, if you see either one of these, it's the same thing. Okay, it's just a different word for each other. They're used interchangeably. Okay. Normally it's above the second rib, at or above the second rib. It normally likes to impinge on your brachial plexus, the cervical lymph node chain, and your superior venous.
Superior vena cava.
Yeah, thank you. Sorry, I said it. I think I need more caution today. Superior vena cava. So you're gonna have that whatever side it's on, right? You're gonna have that Horner syndrome. You may have that swelling in the arm. Your ulnar nerve may be compressed. Okay. Yeah, SBC syndrome. Yep. Okay. So you can see on this guy here, the tumor is on the left, and his left arm is nice and red and swollen versus the right. This one, we don't really know what side, but you can kind of see, like, he can kind of scrunch up one side of his face and the other side doesn't. It's drooping of the eyes. The pupil constricts, okay, and you don't have any sweating on that side of the face. So, what labs and imaging do we need to do in order to figure out what type of cancer it is and where it might be and what we have to do next? So, looking at your electrolytes, looking at your ADH, looking at your ALK-Phos is essential. Okay. Specifically, if your ALK-Phos is elevated and now you have neurological symptoms, bone pain, you have to order either a bone scan and brain CT or most likely an MRI. Okay. So if you have any type of lung cancer and now your ALK-Phos is elevated, you have to start looking for metastasis other places, which is really the bones and the brain. Okay, ALK-Phos is going to be the one to really tell you. If you find any abnormalities on X-ray, okay, you just don't know what it looks like. It looks funky. Get a CT chest with IV contrast. Okay. You might also include the abdomen pelvis. Very commonly when we have these, we're like, oh, this looks like it has, lung cancer. We're gonna get not even just an upper, but we're gonna get an abdominal pelvis X-ray or a CT to really identify the liver and adrenal glands as well as any other spread. Okay. PET scan. It's a critical stage for staging. Okay. We need to know if it's spread anywhere. This is only to assess for distant occult disease. Okay. And that's what this red picture down here says, right? You have a primary lesion in their lung, and you can see that further down where the kidneys are, okay, it's starting to highlight, starting to glow. They may also have some glowing in that, it's probably at least lumbar by then, lumbar 2 or 3, okay? So that's a PET scan. It shows distant disease. You can look at that PET scan and you really can't see much detail, right? It's not made for detail. It's only really made for distant occult disease, okay? We can also then do thoracentesis or a thoracostomy to help evaluate any pleural effusions. We call these malignant pleural effusions at this point, okay? Trying to get some of that fluid off so that they can breathe a little bit better. More so palliative than anything else. All right, so lung neoplasms, benign versus malignant. How do we tell if a lung mass is benign or malignant just on imaging alone? Okay, if it's benign, most likely it is less than 2 centimeters. Okay. Over 2 years, it is stable. It is not grown. Has concentric calcifications. It is a smooth border and it's a solitary lesion. Those are most likely benign. Okay? So if you have someone who has a little lesion on their, like an incidental loma, what we call them, little 2 or like 1 centimeter lesion in their lung, okay? And they have no other symptoms, no weight loss, no cough, no nothing. We can watch that and observe that over the next few. They're going to most likely get at least chest x-rays, if not CTs, every 3 to 6 months. And if it stays the same, there's nothing to do. Okay, it's a benign little lung nodule. You might want to do, at least an x-ray or so every year, just to make sure that you're continuing to follow it. But most likely, if it has not changed over those 2 years, probably not going to. Probably just a little solitary lung nodule, there's nothing to do about it. But if it starts off and it's over 2 centimeters on initial presentation, it increases or becomes unstable over the 24 months. Irregular calcification, spiculated borders, meaning it's not nice and confined. Like, see, this one's nice and round, right, and this one's not. Okay, so nice and round versus not. That's like a spiculated border. Okay, it's irregular. And then if it has multiple lesions, you have multiple things within each lung or within that lung, you have to then assume it's malignant until proven otherwise. Okay. It is also good to know where the areas of endemic coccidiomycosis and histoplasmosis are. Thankfully, well, we're in San Antonio now, so we get both. So we have to look for, they show up as lung nodules, lung things, lung masses, okay? So we may actually have to do like a biopsy of that to figure out what type of bacteria it is, if it's cancer. Okay. All right. What other things do we want to do to diagnose lung cancer? So we want to get the sputum culture, sputum cytology. Okay, it's not just that spit in the cup, really deep cough. We may have to do a bronchoscopy to do that bronchoalveolar lavage if they can't do a deep cough. Okay. Everybody knows what lavage is? Anybody need me to explain it? Cool. All right. Next, transbronchial biopsies. Okay, that's when you go use that camera, go down into the lung, find where that mass is, and actually take biopsies from that mass from inside the lung. And then endobronchial ultrasound, EBUS. That is using the kind of like an endoscopy or bronchoscopy, but on the end, instead of a camera, it's an ultrasound. So we're not actually seeing pictures. We may actually do both at the same time so we can see exactly where we're doing it. But it's an ultrasound from the inside of the lung that we can see exactly where it is. It's not necessarily real close to the bronchus, so we can't see it encroaching on that, but we can use the ultrasound to find exactly where that mass is, and then use a fine needle aspiration or a core biopsy to get into that lesion. Okay. For percutaneous and transthoracic biopsies, this is a good picture. Okay. Transcutaneous meaning from outside in, transthoracic means through thorax. And then wedge biopsies, okay? This is when we actually go in and take a section of that, or we try to get all of that mass out with a wedge of plugs. Okay, but that's in the operating room. We can do that under VATS or open, depending on where that tissue is or where that mass is. Again, if it's peripheral, we may be able to get it under a laparoscopic VATS. Okay, if it's more central, we may have to go in open and actually try to find where that is so that we can take the full lobe. Just depends. Okay, all right. Resectable versus inoperable. Okay, there's difference. So unresectable, meaning the tumor has invaded the structures around it and we cannot remove it, right? It is wrapped around the aorta, it's wrapped around the SVC or IVC, right? If we were to remove it or try to remove it, we would do more damage than just taking it out or just leaving it, okay? So unresectable, we cannot remove it due to its invasion and metastasis into other structures. Inoperable means the patient can't tolerate it being resected, okay? The patient isn't stable enough for the surgery. All right. What do you think we want to look at when preoperatively when we have a lung cancer? When we're going to go to the OR to do something. What do you think we need to do? Think back to that first lecture. We want to know their functional classification, right? Can they walk to the mailbox? Can they walk up a flight of stairs? Advanced age alone is not a contraindication to resect. Just because they're 98, if they're a very spry and mobile 98, we will absolutely take that lung, that mass out. Versus the little feeble 98 person who's in a wheelchair and they may not have the will or the functionality to make it through that surgery, right? So age alone is not a contraindication. We do want a thorough cardiac exam, okay? They have cancer in their lung. We don't know what effects it's had on their cardiovascular status. So hopefully nothing, right? but we want to do some sort of cardiac eval if they've had any cardiac symptoms, any abnormal EKGs, or any suggestive findings of ischemic heart disease. Okay. Now, since this is a point of contention, if you have someone who's able to walk around their block and they're able to exercise, able to walk on their own, do you think they're going to tolerate an exercise on a treadmill to stress their heart?
Sure.
Yes, right? Now, what do you think about that patient who is still mobile, right? Has to sit down every once in a while, but that they're having lung or respiratory symptoms, right? They're having dyspnea, they may have hemoptysis, they may have, because it's obstructing some of their lung, right? They're not ventilating correctly. Do you think they're going to tolerate being on a treadmill? They don't. Okay? It's really, think of, if you really need like a straight line of like who to differentiate needs an exercise versus a chemical stress test, okay? Think of being on an exercise treadmill, okay? For at least 20 to 30 minutes, depends on how cardiovascularly they are competent wise, okay? Person your age, you can run on a treadmill for a long time.
Sure.
Okay, you can run on a treadmill at an incline of 15% for at least enough to get your heart to stress and show up on an EKG and an echo. Okay, you're going to see those things. You have to have a really healthy patient, kind of like functionality-wise, healthy patient to be able to then do an exercise stress test. Okay, if they cannot do that, just order a chemical stress test. Okay? I'll tell you a little bit about me. When I was in Yuma, I walked up one of the mountains one Christmas, the first Christmas I was there, and my heart rate went up to like 220 for a long time. Okay? I'm from Michigan, right? We don't have mountains in Michigan. So my doctor ordered a stress test for me just to make sure. So because I could not tolerate walking up a mountain, they gave me a chemical stress test. I sat on a bed and went through hell getting adenosine pushed through my veins to get a stress response of my heart. I hated it. Okay? Could I have walked on a treadmill? Sure. But because my symptoms came about doing exercise, walking up the side of a mountain, they said, let's just do a chemical stress test. Okay? So those are the types of things that you might need to think about when we're trying to differentiate between, now I was fine and nothing, it was just altitude and not being, either way. But that's the kind of thing that you need to start thinking about when we're trying to decide. And if you can't, just send it to a cardiologist. They're going to be the ones who are really going to decide on whether or not you do an exercise or a chemical. But you should still be able to educate your patient on both. Okay? All right. If the patient has significant cardio or coronary artery disease, they should probably be surgically treated, okay, with either a stent or a bypass or something before we take part of their lung. If they have significant pulmonary hypertension, and if they have had a MI within 3 months of their surgery date, they are an absolute contraindication for that surgery. Okay? We're about to take part of their lung, if not their entire lung, like hemithorax, depending on how bad that cancer is spread throughout that lung. Okay? Do you think taking half your lung, out of the two, half, okay, one side, do you think that's going to put a strain on your heart? Yeah. So if you have just had a heart attack, we don't want to put more strain and cause them to have another heart attack. Okay. Pulmonary hypertension, same deal, right? They're already having that stress. If we were to take even a portion of that lung, their pulmonary hypertension is probably gonna get worse and they're gonna have, issues, okay? All right, pulmonary functions, predictability to tolerate, resection. We wanna do a pulmonary function test and a VQ scan, so ventilation, perfusion scan. To do the PFT, just send them to pulmonologist. We'll be able to do that. And then the VQ scan is a nuclear scan that you can order. Okay, so treatment. What do we got? Observe. Our first treatment is observe, right? If it's, we really don't know, or they are too frail to do surgery, we just observe it. Most of the time, these are the less than 2 centimeter lesions. We really don't know what it is. We're waiting for it to kind of declare itself. This is very stressful to the patient. Okay, observing, no one wants to observe a lung nodule to see if it's going to turn into something. Let me rephrase. Nobody wants to observe any type of lesion anywhere in their body for any length of time if they think it could be cancer. Okay, so this is something that if you truly are, I do not think it's cancer, we're going to observe it, we're gonna get an x-ray in 3 months or 6 months. You may have to spend some time really educating your patient and understanding that pathology so that they're not going home being like stressed out of their mind saying, well, I think I have lung cancer, my provider is making me wait 6 months to see if it's gonna do anything, right? So knowing those characteristics will help you be able to educate your patient, but sometimes observation is really the only option when it's a small lesion and they have no other issues. Okay, it's an incidentaloma. It's the first time we've seen it. They had a chest x-ray because they went to an urgent care because they thought they had pneumonia, right? They actually do have pneumonia, but on the other side they have a little lesion. They're gonna come back to you as your primary care to be like, well, what do I do now? Get a CT, get a real good, like, detailed of what it looks like, and then if it meets those criteria for benign, you observe it, okay? Now, say it's, conservative, it's too big, or they aren't, it's inoperable, okay? They're not, stable enough or it's unresectable. We might need to do antibiotics if it's causing pneumonia, okay? It's more supportive therapies. Pulling off that pleural effusion, if they have it, doing dorscentesis. We may give them steroids in certain cases depending on what the pathology is, okay? Is palliative care. Excisions, okay? Like I said before, we do a VATS if it's peripherally, we do a thoracotomy if it's more centrally, and then we get them in touch with those medical oncologists, okay? We want to know whether or not chemotherapy and radiation therapy is something that's going to be needed for that type of cancer. Okay, I am not going to expect you to know what cancer needs what. We are not surgical oncologists in here. I am not going to expect you to know that a small cell carcinoma needs this types of radiation or this type of chemotherapy. Okay? But I will need you to know what neoadjuvant means, okay? Say the tumor is a little bit bigger and we want to try to shrink it, okay? So we do chemo or radiation before surgery. Neoadjuvant, before surgery, okay? Adjuvant, after primary treatment, okay? We've taken out that lung tissue, their outside of their skin has healed enough. Normally we wait about 4 to 6 weeks, okay? And so that's when we do the treatment of chemo or radiation to reduce the risk of reoccurrence. Okay? So it's not to shrink it, we already took it out. But we sometimes can't get all of the cancer cells out, okay? And so that's when most of the time, depending on what type it is, and I don't, like I said, I'm not a surgical oncologist, but there are certain cancers that will need both, that will just need radiation, that will just need chemo, okay? But that's after. Adjuvant is after we already took it out, trying to prevent reoccurrence. Neoadjuvant is before, we're trying to shrink it so that it gets to a point where we can surgically remove it, okay? All right. Staging. This is important. Why do you think this is important? Someone comes to you. Prognosis? Yeah, they come to you and they say, hey, I've just been diagnosed with stage 4. Let's say T3 N2 M1. Bad, right? T3, tumor is greater than 7 millimeters. It's metastasized at least to the same side and is distant metastasis. Okay. Probably not great. Okay. So knowing the basics of how the T, M, and N structure for cancer staging works, this is the same cancer staging for every single cancer. Whether it's colon, breast, brain, lung, bone, doesn't matter, it's the same. Okay. There may be slight differences in terms of metastasis to where, right? If it's breast, it's not going to metastasize to the breast. If it's liver, it's not going to metastasize to the liver. It's going to metastasize outward, right? To other places. So that may be the only real difference. But in terms of like the basics of tumor size, nodal involvement, and metastasis, basically the same. Okay? This is a lot. I'm going to say at least know the little chart. But if you are dealing with, when you get out to your, being a primary care PA or a specialty PA, some of your reservists, if you're dealing with any types of cancers, you probably will have this posted, the big one posted in your, somewhere in your office, because you're going to use it on a daily basis. Okay. But for us, we're going to use this little chart. I want you to be able to kind of understand on what the tumor size means, what the lymph node means, and what the metastasis means. Okay? Alright. 62-year-old man, heavy smoker, presents with complaints of general malaise, occasional cough, weight loss of over 10 pounds. The last 2 months he does not report any travel, recent infections or use of any medications. He does have borderline diabetes, controlled with diet. Reveals some mild peripheral edema and extremities, clubbing bilaterally. Blood work shows mild anemia and a sodium of 122. What is the next test? Who says 3? Good, you are correct. Always do a chest x-ray. Okay? Go take a 10-minute break. When we come back, we're going to be on the next slide, the next show, or whatever, the next fucking PowerPoint.
Y'all get a gift card to Golden Brown. Go crazy, kids.
Just to, sorry, part of the reason drawing off that view is what we are.
There's one like more northern, one more south.
Yeah, so we want to go to
Memphis, Nashville. Which one? It just depends where I want to visit. Like I came through Louisiana, so I was like, Lafayette.
Where the fuck are these coming from?
They're like, no.
I don't even like that soccer.
For him, because he's from Miami. No, it depends where you want to see.
Well, you just said nobody knows who it is. So what makes you special?
It's like a difference of like 20.
Don't make me feel better.
It's major highway.
Hey, the general.
Yeah, that's what I'm saying. It's major highway.
Did it kick in?
What do you want to drive?
I would, if you don't care, I would go after the hotel. Which hotels have the best, like, rating. Like, they don't rate the car, and security, like, that's because you have stuff. So that's why I would say, if you don't care.
We're allowed 5 days of travel.
Yeah, because it's like a 5 hours, like 5 hours.
Yeah. Gotcha. Yeah, so like,
I did, but you're not accepting that.
Who got my ass?
yeah.
Scott,
I thought it was time.
What do you mean?
Time out.
let's see what he texted.
I think I can come back.
You put the super hot fire truck in.
So technically, we're allowed.
Oh, yeah, it was like, you know who that is?
Well, you're probably, but
I
you
used to watch him.
I don't think it was the video that plays like this.
Glasses.
No, but it has to be different days. Because like they're not gonna like when you clean total. I clean because when I did they don't need receipts for anything under $25. So every other day I clean like $50.
No.
They're gonna have to, yeah, it'll be
But you don't need a receipt for that because.
I also you having gotten these to get the yeah, but parking they want the receipt. They might want the receipt.
But the tolls.
I do that.
Nah, dude. You don't smell that?
We are gonna go get it. I just do every other day.
Just say you're incompetent.
Just leave your one.
Or you could do
What's your sense of use?
My comments about here, you know, like, the hotels are cheaper through these two.
So we're leaving on Saturday. It's our last day of
That's all I see. So I'm like, that's so really.
we're our last day is on the 7th.
And when Chelsea goes, oh, you guys have to come. What are you gonna do? We're out to sleep.
So we're just keeping our breakfast. Where's that?
One time I just feel like a bunch of like not comforters on the floor, I was on the floor, and I had a projector and I kept my Wi-Fi. It's a nice one. I've been in that. It's expensive. I want like 200.
Nothing on Friday.
Nothing on Friday? No shot.
It's the best Western I've tried that is a lot cheaper and it's nice. Not best Western. It's a nice hotel.
Oh yeah, the second Surg exam. Oh.
Probably like an 80.
Are you guys not getting like the updated schedules?
Oh, I am. I just was asking for.
So the first
first schedule that went out did not take into account all the time I was gone, because literally the day it went out, I got the, hey, you've been invited to do this 2-week class, and I said, so I pushed everything. So yeah, the schedule is different. Make sure you look at the most up to date
I have
schedule.
it, I'm just trying to see if you can go off.
But you're not the first one to say, oh, the surgery test moved.
That's insane. I was just asking, I was just texting you.
It's like, it's right outside the gate.
I didn't know you were like.
Do you know it's
You didn't answer this. I'm thinking you partial. I'm thinking you partial credit. You just didn't answer the question. I can't miss it now. I've done that before. I was waiting my test. Like, oh, I think you answered it.
Oh yeah, we called that.
Because I wrote it down.
It tells you, yeah, I didn't answer the question.
It was like timing out. You didn't answer the question. Like, well, question. Yeah, scroll all the way to the top, look at the thing, scroll all the way back down to 46, and you're right there.
Yeah, no, all that rain is yeah.
I wonder how much it is.
Only like 50 some slides to get through. I really want to try to get through in the next hour. We're gonna go through this pretty quick. A lot of this is review. Okay. This is really when, like, more so for primary care, mostly for the ER, when you have that acute belly. Okay, someone comes in acute pain for their belly. Okay. We have the next week to go through all of the individual things that can cause belly pain. So this is just a quick overview of some of like the major concepts of when you see somebody with an acute abdomen. Okay, an acute abdomen equals emergency surgery. Okay, they're at risk for perforation or they've already perforated. Okay, it's a little bit different than when you have someone with a, kind of a mild small like or early appendicitis or a chronic like chole issue or that kind of thing, right? Or even a small bowel obstruction, but maybe a partial bowel obstruction that is early, right? They're not at risk of perforation yet. They're not at risk of damaging their intestines yet, okay? So those are your objectives. Okay, so when you're thinking acute abdomen, knowing your abdominal anatomy is critical, right? If they say I have right upper quadrant pain, knowing what's in the right upper quadrant is super important, okay? So when you talk about location, you must know the territory, right? Know the normal anatomy. Normal anatomy. People are going to surprise you and have weird anatomy sometimes, but think horses, not zebras, okay? And then what abnormalities are going to kill you fast in those regions, okay? If you have a little lady who shows up with right lower quadrant pain and said, well, yesterday I had 15 out of 10 pain, and then, well, it got better, and now I'm just sick. I'm just malaise, I have fevers, right? That most likely had an appendicitis that burst yesterday, okay? Now she has a peritonitic belly. She's septic because now she has a huge abscess forming inside her belly around her appendix, okay? So, general tracts, you have the GI tract, mouth to anus, okay? Okay, when we talk about the biliary tract, that's liver, gallbladder, pancreas. When we're talking about the genitourinary, kidney to urethra. When we're talking about regions though, there's 3 regions. There's the foregut, so the upper, so esophagus, stomach, starting at the first part of your small intestines, your duodenum, okay? When we talk about the midgut, small intestines, that's your duodenum, your jejunum, your ileum. The hindgut, large intestines, your colon. Areas outside the abdomen you still have to be aware of, right? So we'll talk about some anatomy on what is included actually inside the abdomen and what's not technically inside the abdomen. We have the retroperitoneal space, the pelvic organs, like the pelvic space, okay? So when we talk about the abdominal wall, you have to know your fascias. Just like with the chest, same thing as with your belly. Okay, you have the visceral pleura, and then you have the, the peritoneum, okay? The parietal peritoneum and the visceral peritoneum. Parietal goes along the wall of your abdomen. When you talk about visceral peritoneum, that is around your intestines. Okay. What separates your retroperitoneum from your peritoneum is that parietal peritoneum. Okay, so this sits on top of your kidneys, making your kidneys retroperitoneum. And it's behind the actual peritoneum. Okay? What also sits retroperitoneal?
Aorta and vena cava.
Parts of the colon. Sure. Parts of your ascending, parts of your descending. I think I heard it over here.
Aorta and inferior.
Aorta,
inferior
IVC.
vena cava.
Okay? All the big vasculature is retroperitoneum. Okay? So knowing those different regions is super important. Okay. This one, there's a lot here. This is a very overview on if you have a disease process in whatever region, these are the most common things that you should start thinking about. Okay? I will not test specifically from this slide, but this will help you the rest of the semester. Okay, if we're talking about the upper GI, if we're talking about the right upper quadrant, if we're talking about the left lower quadrant, you already then have an idea of what types of disease processes can happen there. Okay, so this is just a good overview. I know it's small, you can print it out, make it bigger, whatever you gotta do. This will help you the rest of the semester. Okay. All right, generalized anatomy, right? When we talk about the stomach, we have the actual stomach, we have the cardia, where the esophageal junction is, esophageal gastric junction, where your sphincter is, where your lower esophageal sphincter is, okay? You have the fundus, why do you think we need to know the fundus? Where the gastric bubble is, right? Okay, the body, pylorus. When we talk about the actual gastrointestinal tract, we'll get more in depth in this anatomy when we talk about the upper and lower GI tracts. Okay, this is just a very basic. This is actually the small intestine. Okay, but the biggest thing is that you know that you have muscle. They have 2 layers of muscle. One that runs circular and one that runs longitudinal. Okay. When we're looking at tears and ulcers, knowing the levels and layers of the intestines is really important. Okay? If you have a duodenum ulcer, right, you need to know if it's gone through the mucosa or submucosa, okay? Because if it's already gone through the submucosa, most likely it's going to perforate pretty soon. Okay, the only thing left is the muscle. Plus, if you know these layers, you're going to look stellar on your phase 2 with the surgeon. They will ask you this. Okay. All right. Foregut blood supply. Things that you need to know. Common hepatic, right? You have the big celiac trunk. First one off is the common hepatic. Then you have the left gastric, and you have the splenic. The celiac trunk is the main supplier of your foregut. Okay? I'm not gonna make you know all the rest of these. You learn these in freshman with A and P. Okay, I'm not gonna make you know, you should know all of them, but the ones that I want you to know are the big ones that supply blood, because these are the ones that we have to make sure we ligate if we do like a splenectomy, right? Or say we have an ulcer in the body, but it's an anterior ulcer or a superior ulcer. What blood supply do you think it's potentially coming from? The left gastrics, okay? That's why that's important. All right, blood supply review to the midgut. Okay, so you have your superior mesenteric vein coming off your aorta. You have your jejunal and ileal arteries. Okay, you have your ileocholic artery. Then you go into the right and middle colon artery. Okay, these are what supply basically your first part of your colon. Then we get into the inferior mesentery, and that's what does your left colic artery and your sigmoid arteries. Okay, so if you have a sigmoid pain, right, you have a clot within your mesenteric or inferior mesenteric artery, you're most likely going to kill the left descending colon, your sigmoid colon, right? All of that stuff is in trouble. So knowing what supplies what is really important. Now, you do have this marginal artery that kind of comes back and does some what we call watershed. So you do have some, like if one is out, sometimes it helps kind of go back and forth. Just like your radial and ulnar artery, right? Your ulnar arch, same kind of concept, right? So you do have some tributaries that go over to the other side from the IBC or from the IMC or IMA. Sorry, I really didn't need coffee. But most of it, I just want you to know, like if we're talking about like the ileocholic, if we're talking about the small intestines, or if we're talking about the sigmoid colon, like think about the major arterial blood supply. Okay, visceral versus parietal. Same thing as the parietal. Visceral and, visceral and parietal is the same in your chest as it is in your gut. Okay? Your parietal pain, somatic. It's very acute, it's very pinpoint. Okay? It's where your appendix is irritating that, so that appendiceal abscess is now irritating your parietal peritoneum. Okay? Versus visceral pleura, it's actually on the intestine. The intestine isn't what hurts. Okay? It's the inflammation or ischemia that's in a direct insult to those nerve endings. Okay? So when your intestines dilate, it's not your intestines that are actually causing the pain. Okay? Does that make sense? Okay? Same thing with chest, same thing for belly. Okay. All right. So identifying that acute abdomen. These are old cards. OPQRST. Nothing new. Okay. Again, this is the same kind of thing in terms of systems versus location. So good to know. I won't necessarily test you on this one, but it's good to know. Okay. But what kind of things do you want to ask when we are dealing with an acute abdomen? Fever, appetite change. Do they have any trauma? Is this a 12-year-old kid that just got a handlebar to the gut? Okay, kind of changes your differential. Cardiopulmonary. Abdominal pain sometimes starts as chest pain because it's irritating the diaphragm. Okay, liver issues actually can irritate the diaphragm enough to cause pleural effusions. You won't necessarily suspect the liver because it's a chest issue that they come in for. Nausea, vomiting, diarrhea. We want to know if there's blood in the stool, whether it's bright blood or dark blood. Okay. If they've had any prior recent studies, an EGD, did they just have camera and air go down into their esophagus? Okay. Okay, now they're having difficulty breathing. Did we just rupture their esophagus because we put too much air in their esophagus by the EGD? Biliary, jaundice, hepatitis, gallstones. Okay, we want to know if they've ever been diagnosed with this stuff. If they are here because of chronic pancreatitis or acute on chronic pancreatitis, when was their last bout? Okay, when was their last episode? Histories of hernias, last menstrual period, are they on OCPs? Could they be pregnant? Any history of STIs? All of those are extremely important when we ask review systems and specific OPQRST questions for acute adjuvants. Okay? Focused exam. This is not a comprehensive exam. This is a focused exam. Okay? We want to do heart and lungs and belly. Okay? Begin with vital signs. We look at their GCS. If they're not 15, did you learn GCS yet in EM? Yes? Okay. Well, I'm not necessarily gonna do much with it this block, it'll be more so next block. But if it's not, what actually is the cause? Is it confusion? Is it they can't lift their arms, right? Like what is their eyes doing, their voice and their motor, okay? Distress, okay? Are they just chilling in bed on their phone, not in distress? Or are they in so much pain they are lying still? Or they're in so much pain they're writhing and they can't find a comfortable position? All of those things are clues as to what we need to start investigating, okay? Peritonitis, they will lie still. They do not want their belly to move at all. They will have a positive heel tap. They will be guarding. They will have rigidity. They will have a positive rebound sign, okay? All of those things, all of your tests are gonna be positive because their parietal peritoneum is inflamed, okay? Peritonitis. They will lie still. Now, if it's obstructive, okay, now their visceral peritoneum, their intestines are distended because it's obstructed. They're gonna be like, their whole belly is kind of this weird concoction of like, I just can't find a comfortable spot. Nothing feels comfortable to me. Okay, it's not to the point of peritonitis. It can lead to peritonitis, okay, if it ruptures, but it's just this overwhelming sense of, I just don't know what's wrong, and I can't find this comfortable place. Something is wrong, but we don't know what, okay? Ask them to point to where they actually have the max pain, okay? Don't have them actually point to it, right? It's one of those like, if they have right upper quadrant pain, you aren't even gonna start at the right upper quadrant. You're gonna most likely start at the left and go down and then finish on that right upper quadrant. Once you start palpating where they have pain, if you cause them pain, they are not gonna let you touch them anymore anywhere else, okay? So do your light all the way around and then do your deep all the way around, okay? End with that deep in that area of most pain. You probably won't be able to do deep because they're in that much pain, okay? But at least you have done the rest of your belly exam before they tell you to stop, okay? You have to examine above and below, okay? So if they come in with belly pain, you have to make sure it's not a lung issue, okay? You have to make sure it's not a pelvis issue. Need to make sure it's not a back issue, okay? Meaning either MSK or is it a kidney pain? Is this a kidney stone pain that they're not having referred pain elsewhere, okay? And then rectal, making sure that their prostate is not high riding, that it's not inflamed, that it's not having prostatitis with discharge or infection. Is there bleeding just from hemorrhoids, okay? Or do they have fissures that's causing their pain? Just depends. All right, when we're doing physical exam, inspect first. You always look first, you don't touch. We all know this, right? So what are you actually looking for? You're looking for bruising in specific areas. You're looking for scarring, okay? Maybe they've had surgery. Maybe it's a recent surgery, okay? Versus an old surgery, okay? That scar is a midline laparotomy. So that's an exploratory laparotomy scar. Okay? Versus this is an open appendicitis or open appendectomy scar. Okay? So just knowing where the scars are, I can almost guarantee I can tell you where or what they did. Okay? This being up here, that's a gallbladder. That's a cholecystectomy. Okay? If the appendectomy had a belly and then two little lines on the opposite side on the left, I know that they've done something with the appendix. Okay? So scaphoid knowing versus so scaphoid or obese, right? If it's scaphoid, they're probably malnourished. You can think maybe an ulcer. Okay, they haven't eaten. You may also see that with mesenteric ischemia. Okay, they don't eat because every time they eat, they puts their gut to work, but they can't get blood to their gut and it hurts, so they don't eat. Okay, they just don't do the thing that causes them pain. Okay. Soft, doughy fullness. Doughy is a surgical term. Okay, once you feel your first doughy, soft belly, you're never gonna forget it. Okay. Most of the time, I don't necessarily feel it with an ileus, but it is like pathognomonic. If I have somebody who has a soft, doughy belly and pain out of proportion in their belly, my first thought is mesenteric ischemia. They have some sort of clot in their vasculature and their gut is dying. Okay? Now, there are a lot of other things that can cause a mesenteric thrombus. I've had one patient who had a soft, doughy belly, pain out of proportion, did multiple CTs, multiple x-rays, could not figure out what was wrong with him. Day 5, he did his daily chest x-ray, KUV, he perfed. They were there underneath the belly. They're underneath the diaphragm. Okay? When we got into his belly, I think 5 feet of his intestines had died because it was a long volvulus. Okay? So it twisted on itself and the majority of his gut wasn't getting any blood supply. Okay? So it acted as if it was a mesenteric ischemia, but it really didn't identify until that ischemic bowel perforated, and he unfortunately didn't make it. I do have a picture of that bowel if anybody wants to see it. I don't think I have it in the slide deck. I normally don't put it up because it is kind of disturbing. Okay. Everted belly buttons. Okay. Now, you have to ask the patient, is this what it normally looks like? Do you have an outie? Right? Or are you so perturbed and so full with ascites that now your belly button that's normally an innie is now an outie? Okay, we see this a lot with pregnant ladies. They start with an innie, the more their belly grows, the more it pops out. Okay? Same thing with fluid or with a mass or with any type of intra-abdominal pressure. All right, auscultation. Auscultation is weird in surgery. Okay? It really depends. And this will get more complicated and more the further we go on. But normally, right, what we hear, those bowel sounds, is the peristalsis. It's the fluid and food going through the small intestines. That's what you hear when you're listening for bowel sounds, that peristalsis, okay? So when you have active or absent bowel sounds, most likely an ileus, okay? When you have hyper or hypo, could be normal. If it's high-pitched, most likely you have some sort of obstruction, okay? Hyper could also mean you have a GI bug and your bowels are actively trying to expel whatever you ate, okay? Or you have the norovirus and your body's just producing diarrhea, okay? Hyper means it's hyperactive, that peristalsis is really hyperactive, but it could be normal. Hypo could be normal, you just haven't eaten lunch that day, or you haven't eaten yet, okay? It just depends. very rarely in surgery do I actually listen for vowel sounds unless I am looking for an obstruction or I'm looking for a change. Okay, but for the most part, absence equals ileus. Absence could also mean obstruction. Okay, if you have an obstruction, a complete obstruction, and food and stuff is not moving forward, you're not going to have vowel sounds past that point. Okay. Alright, any questions on this? It will get a little more confusing when we get into more of the specific diagnoses, but not too bad. Alright, percussion. Dullness over solid organs, tympanic over everything else. Okay? Gas filled, so over your gastric bubble, you should have a little more tympanic versus over your liver. Tenderness to percussion, most likely peritonitis. Okay? If you have tenderness to percussion, you should be doing a heel tap and you should be doing rebound testing. Most likely it's going to be positive. Observe for discomfort moving on and off the bed. Are they really gingerly getting on the bed? Are they, just fluffing down? They don't care. Most likely they're probably fine. Okay. Do they hurt when they cough or sneeze? This is really bad. Pneumoperitoneum. Okay. Really bad. All right. Palpation. This is the most informative aspect of your physical exam. If for whatever reason all you do is palpation, sometimes that's all you need. Okay? Because you're looking for guarding, you're looking for tenderness. Like I said before, you want to do that light palpation before you go through the deep. Okay? So don't start with light and then go deep in the same quadrant. Okay? Do your light and then your deep. Okay? Because if you go deep and you accidentally cause them pain, most likely they either could go two ways. They're not going to let you do the rest of the exam, or that caused so much pain in that region that you're going to get abnormal results in the other regions now because their belly is now activated in that pain response. Okay? So light, then deep, but always start not in the, always end in the area of most pain. Okay? You try to distract the patient. Okay? When you're doing your, if you really just are like, maybe they're malingering, maybe they're just like, they really don't know, or it's a kid, okay? When you're listening, and you really want to see like, are they actually, or are they just kind of maybe playing? Put a little pressure when you're listening, okay? And then if they jump at the same pressure with your fingers versus listening, probably something's not right with, they're playing around, okay? Or they're trying to get pain meds or something. Looking for specific signs, Roving's Murphy's, psoas obturator. You don't necessarily learn Murphy's in your Clin Skills 2, but where is it? Yeah. Oh. How about McBurney's? Sorry. Anybody remember McBurney's? I know you, sorry. You,
2/3.
yeah, so you learn Murphy's. You don't learn McBurney's, which we'll learn when we do appendicitis. Okay? So McBurney's is you find your PSIS, your belly button, and then about 2/3 in, that's where McBurney's point is. Okay? Okay. All right, and pain out of proportion, especially in a patient who already has confirmed like cardiovascular or coronary artery disease. Okay. Do you think someone who has arterial disease in the heart, do you think the vasculature knows and then it's only going to attack the heart? Or is it all of your vasculature? All of it, right? Atherosclerosis does not pick where it wants to go. Okay? If you have atherosclerosis in your heart, you most likely have it everywhere in your vessels. Okay? So you have a higher suspicion of having some sort of a thrombus or some sort of an ischemic attack when you have somebody who's already a cardiopath. All right, rule out chest. Okay, inspect, auscultate, palpate. Anything that you've always done. Okay, tactile fremitus, CVA tenderness, absolutely. I will always tap on the back of their back. Okay, over their kidneys. I need to make sure that their belly pain isn't referred pain from their kidneys. Genital exam, okay? More so with males than females, because a lot of, I mean, they have stuff on the outside that is attached to the inside, right? So testicle pain actually may start with belly pain, especially in the younger population, okay? It's that referred pain, right? So always do at least a visual exam, making sure that there's no adenopathy masses, discoloration, there's no crepitus, okay, that's subcu air. Looking at the inguinal and femoral rings, which we'll talk about when we do hernias, okay? Deciding whether or not you need to do a pelvic exam on a female, okay? Is there anything in their history that might suggest that this is a pelvic inflammatory disease, okay? Or is this a tubal or ectopic pregnancy, okay? Sometimes, especially appendicitis, okay? Same region as your ovaries. Maybe you have an ovarian torsion, okay? Kind of acts the same way as an appendicitis. So if it's, especially if they still have their ovaries, I would also do an ultrasound of this region just to be sure. Ovaries do not really show up well on CT. So if you don't know, and they've had any history of like maybe ovarian cysts or, really if they just have their ovaries, throw an ultrasound on them and see. You can do a Doppler pretty quick just to make sure that ovary is still getting blood supply. Okay. And again, any discharge, is there asymmetry? Okay, is one testis really large versus the other? Okay. Rectal exam, not everybody needs a DRE, but if you want to inspect, okay, belly pain or perianal abscesses can show up as belly pain, lower belly pain, okay? Just depends on how internal that abscess started or how much it's tracked up. Okay. So sometimes we need to do a rectal exam to see whether it's the prostate, whether you have internal hemorrhoids, where you have abscesses, and to look for that gross blood. Okay. What labs are important? CBC, CMP, UA, all the time. You get those every single time. Okay. We want to look at hematocrit. We want to look at the what blood cell count. Is this an infectious process? Electrolytes, we want to look for hypovolemia, okay? Lipase, look for pancreatitis. We'll do that more when we do the pancreas. And then any liver function tests. So the liver function tests do not come from the CMP. They are a separate lab. Okay, they're separate lab. Now, yes, you can get some things, some liver enzymes in the CMP, but if you really want to know, like your total billy, your direct billy, your outfos, your AST, ALT, you have to do a separate liver function test. I want to know what your clotting studies are doing. I want to know, especially if it's something that we're going to need to go to the surgery for. If it's elective or urgent, I'm going to do a type and cross. Versus if it's emergent, I'm going to do type and screen. Okay. We do this on every surgical patient because if we get into trouble and we have a lot of bleeding that we're not expecting, we need to know what blood type you are. And if you have any weird, enzymes or factors in your blood. Now, the screen literally just is A, B, O, AB, and your RH factor. Just a screening. They will reflectively do a cross as well. Okay? But this is just a generalized, very quick, it comes back within like minutes, maybe not minutes, maybe like half an hour, where we can give them like their actual blood type versus the universal donor. Okay. Cross is when we have a little bit more time. We really want to know, do they have any weird enzymes? Do they have any like really crossing that blood type with them so that the risk of reactions is a lot lower. Okay. So we do that for every surgical patient. And most of the time, if they're going back to surgery, it only lasts, unfortunately, for so long. It depends on the hospital. When I was at Cook, I think we had to do it every 7 or 10 days, something like that. So if we had someone who's going back You know, the next day we would get a cross again, if it's been 10 days or something like that, because they need to have a current one on file for their blood type. Especially people who've had a lot of transfusions, their enzymes and their stuff in their blood may change, right? Say they have a massive trauma and we've given them 60 units of component blood. Do you think their blood inside their body is the same that is what they started before their accident? We probably have replaced it with donor blood many, many times over, okay? So figuring out how their body has reacted to that blood, if it's had any other different antibodies, the type and cross will find it, okay? And then for anybody of childbearing age, we do a urine HCG. If we can't get any urine, we'll do a beta HCG, it's the blood type, so at least we know if they're pregnant or not. All right, imaging. EKG, upright chest x-ray. Upright chest x-ray. Everybody who has an acute belly gets an upright chest x-ray. We may or may not do a KUV. We may or may not do the 3 series abdominal series. Okay, the flat upright chest x-ray. Okay. And the upright is the belly, upright belly, and then chest. Again, if we're looking for pneumoperitoneum, we're just going to do that upright. And if it's positive, we're going to go on. If it's negative, we're probably going to do a CT. Okay. Very rarely do we do an abdominal series. All right, abdominal ultrasounds. Most people. Okay. We can do ruckuses, looking for gallstones, looking for gallbladders type stuff. For female, we may do vaginal or transvaginal, like lower types of ultrasounds, looking for those female specific conditions. And then we'll most likely do a abdominal and pelvis CT with IV contrast. Depending on what we think it is, we may add PO contrast or per rectum contrast, okay, which is fun, not for the patient. If we feel like we need to add on a chest, we'll add on a chest, okay. It just depends on what we think the pathology is, but for the most part, an acute abdomen will at least get a CT and then pelvis with IV contrast. Okay. I'm not going to go over these because these are the same slides as last block, just review. A lot of you missed that. Okay, when we're looking for pneumoperitoneum, you want an upright chest x-ray. Okay? This was on the last block. Again, stacked coins, small intestines. When we see segmented pouches, we see colon. Okay, gravity, splenomegaly. Okay, calcifications, this is a new one. Okay, we want to look for those calcifications. Right, there are calcifications in the vasculature. Okay, can we actually see the plaque that's lining their aorta, their iliacs, their SMA, IMA? Okay. Do they have calcifications in their bladder, meaning stones, right? If they have calcifications within the bladder wall, like this, that almost looks like an abscess within the bladder, that is never good. They should see someone like Dr. Evans, a urologist. Okay. Now, if they have cloud-like amorphous popcorn type calcifications in the pancreas, most likely they've had chronic pancreatitis at least, chronic pancreatitis. It's not even at least, they've had chronic pancreatitis. Okay, there has been some sort of inflammatory or some issue in their pancreas causing inflammation, okay, which then leads to these calcifications. Okay. One equals the other. All right. Phebeliths, okay, these are venous thrombi. They're normally small, round little calcifications. Can be seen a lot of places. In women, it's in the pelvic veins. When you see fecaliths, though, these are little calcified balls of stool. If you have a appendiceal opening, and it'll cause that to block off and cause inflammation and tumors. Okay, so just know the difference of those. All right. Again, review. Remember, when you're looking at axial, looking from the feet up. Okay, so the right side is always the right, left is always the left. Okay, you're looking from the feet up. Coronal, you're looking from the front to back. When you're looking sagittal, you're looking from the side. And most of the time it's from the left, so the left is normally first, going to the right. Okay. All right, contrast. Did you guys go over contrast in radiology? Yes. Okay, so there's three main types. There's iodine-based, there's barium, and then there's gadolinium. Okay. For surgeries, whether it's IV, oral, rectal, we're going to use an iodine-based contrast. Okay, which if people are allergic to iodine, allergic to shellfish, this is why we need to know that. Okay. Omnipaque is a big one now. Gastrographin is pretty common too. Iodine-based, it's a water-soluble contrast. Okay, so if it spills out into the belly from the gut or from the intestine, it's not necessarily caustic. Okay, it's water-soluble. We can irrigate it out. Not that big a deal. Gadolinium only used in MRIs. Okay, so when you see gadolinium, it's an MRI. When you're looking at iodine, it's a CT. Now, barium sulfate, diluted barium sulfate is something that we use very rarely for very specific type of procedures. We use it for like barium enemas, okay? When there is no risk of perforation. If there's any signs or you have any spidey senses that there's a perforation, do not use barium. Barium is very caustic to the belly. Okay, so if you have a perforation and you have barium inside that peritoneal cavity or the peritoneum, it's not going to go well. Okay, so always use a soluble, water soluble if you think that there's a any sort of perforation. Okay, so upper GIs, barium swallows. Okay, this is something when we're looking for motility of the esophagus. Is it working correctly? It's under a fluoroscope. Okay, they're basically under a specialized X-ray that works in motion. They swallow, and we watch this barium go down their esophagus. Okay, is the esophagus actually working? Okay, we use these for older people who've had strokes. Okay, we want to know, is the motility working? Does the function work for the esophagus? When we're doing a esophagram, okay, we're looking at the esophagus, stomach, and duodenum. If we want to do a small bowel follow through with the upper GI, we can. It just takes more time, time radiograph. These we would normally do if this is like a week or 2 weeks later from, let's say, an anastomotic thing that we did. We want to check for leaks. We'll start with an iodine-based, like Omnipaque or Gastrographin. Okay, and then as long as we don't see, because it doesn't show up as well on these types of studies, but as long as we don't see any sort of leaks there, we'll do a barium, and then that's like the actual true test. Okay. We can do barium enemas, like I said, this is per rectum. A lot of times we do these if we are really looking for specific, like colon cancers, we can do these, or say we've done a diverting colostomy and they have a stump and now they want to be put back together. Okay, we'll do a barium enema and actually see how much of their stump they have left. Is there disease in their stump? Did it stricture down? Okay, so it's basically a surgery prep to see, can we actually have enough tissue there to reattach what's there. Again, those are, most likely started with iodine-based contrast to rule out obstructions or rule out any perforations, and then if we need a better, crisper picture and we know that there's no perforations, there's no leaks, then we might do a variant. Okay. Retrograde urethrogram and cystogram, we'll talk about this a little bit more so when we do the pelvic injuries. But a rug basically is we use non-diluted contrast, iohexol, okay? And we use one of those big syringes, and there's a picture, like an x-ray, and we're actually holding the shaft of the penis, and we push the contrast in through the urethra, and they take a picture at the same time. This is how we diagnose if there's a urethral injury in trauma or mainly trauma, okay? And then when we have a nice clean, crisp urethra into the bladder, we'll put the Foley in and do the cystogram with the contrast, okay? We instill contrast, we get the bladder nice and big, okay? Nice and big with that contrast. This is a fluoroscope. On x-ray it'll be backwards, okay? The tissues will be more gray and the contrast will show white, okay? But on fluoro, it's the image is inverted. Okay. But basically what we're doing is we're taking a picture, we're instilling that bladder, getting it nice and big, taking a picture of the front and then from the oblique so that we can see behind it, making sure that there's no contrast leaking from around it. Then we drain the entire drain it, so all of the whatever we just instilled into their bladder is back into their urine bag. Take another picture onwards and obliquely to make sure that nothing has leaked posteriorly. Okay, this is how we diagnose a ruptured bladder. All right. There's more pictures. You can look at those. Ultrasound, we already kind of talked about. Good for solid versus cystic structures. Doesn't really do well with air-filled organs. Nucleus testing. Not really used in the acute bladder. MRI is not really used in the acute bladder or in the acute abdomen. Okay, they take too long. They're really not going to give us anything that a CT doesn't. Okay. All right. We'll go over this and then we'll be done for the day. So laparoscopic versus laparotomy. Okay, laparoscopic, just like when we were talking about the chest, it's with the cameras through the small little ports. Okay, there's only so many things we can do. We can still do gallbladders and appies, and we can take out bowel through these little ports. We can do hernia repairs. We can do what's called a diagnostic diagnostic lap. Okay, so we use this more so in trauma. Okay, when you have little stab wounds, or maybe you have a, that picture that we had the last block with the bird shot, right? We'll just go in their belly button, put a camera in, look at the inside of the peritoneum, okay? If there's no bleeding, there's no violation of the peritoneum, we're done. Okay, then we don't have to cut them open. If there is, we'll pull that camera out and we'll do a full-on exploratory laparotomy. Okay, we cut from the sternum to the xiphoid, opening everything up so that we can actually see and touch everything in their belly. Pros to laparoscopic, same as with the chest. Less operative pain or post-op pain, quicker baseline function, shorter stays in the hospital, smaller scars. Again, may have to be done multiple times for abscesses. Okay, may have to convert to open if we see something that we can't deal with laparoscopically. Open, so laparotomies, just like a thoracotomy, laparotomy. Okay. Open abdominal surgeries. These are normally reserved for major trauma, complicated surgeries, disease processes that are very complicated. When we're doing things like Whipples, right? We're taking out pancreatic cancer. We're not going to try to do that through little tiny ports. Okay, it's very, very tiny structures that they need to have visualized for, a good visual for. Okay, so complicated surgeries. There are even some gallbladders that we may have to open, okay, because there's a huge stone. We'll talk about that in the next block next week. Okay. We can do open appendectomy. So if you go to phase 2 and you have an old surgeon, They're old school, they never really learned on the laparoscopic, they may do only open surgeries, they may only do open hernia repairs, only open appendectomies, probably not do choles, but they love doing open because that's what they trained on, right? Very few and far between now, but I did have a surgeon who was when I was at Lejeune, he was 70. He had just kind of retired from his personal practice, but he, went and came to Lejeune for his retirement, and he's 70. He loved doing open shit. We hated it, right? It's not, it causes more pain, causes longer hospitalizations. So